much for that, Debbie. Really enlightening. I have to say, though, the next slide, please, but did bring back bad flashbacks from Chris Whitty during the COVID pandemic, so got some palpitations during that point, but otherwise really informative and a really good introduction to the day. I should say that we're going to have a Q&A session at the end of the three speakers, so we'll get them back up. You will have questions, I'm sure. We'll get all three up together and we'll do it all in a oneer. So I'd like to now introduce Anita Banerjee, who's been a great friend of the work over the last while. She has asked me to keep her introduction short, and I think that speaks volumes around about the huge body of work that she's done in this space. So Anita is an obstetric physician. She's a diabetes and endocrine consultant. She's honorary reader in obstetric medicine at King's College London, from where she graduated. She's got huge interest in health inequalities, education, high-risk pregnancy, and cardiometabolic health. She's a founder member of the RCP Obstetric Medicine Diploma and co-authored the RCP Acute Care Toolkit. And she was the lead obstetric physician for the first Ockenden report. So I'd like you to put your hands together and welcome Anita. Thank you.
Brilliant. Thank you for that kind introduction. Thank you to Debbie and all the rest of the organisers for inviting me. And wow, what a day. Look at you all. You know about me. How about you? So I just want to know, my audience, who here are midwives? Can you just put your hands up? Excellent. Thank you. Obstetricians? Fabulous. Anaesthetists? Excellent. Critical care nurses? And anyone else that I've missed? Pharmacists? Excellent. So there's lots of people here from the multidisciplinary approach. So I've got 30 minutes, and my remit was to give you the current national medicine, maternal medicine picture. But really, what I really want to do is start with the history of maternal medicine and where we started. So I want to go back, way, way, way back to Egyptian times. Okay. So when we were in the Egyptian time, they didn't have a word for midwifery or obstetrics or anything like this. But what they had was that every woman was delivered by either a friend, a neighbour, a family member, or a servant. And that woman actually stayed with that woman's life, not only for delivery, but preparation of delivery and pregnancy, but her long-term life, okay? So that's really interesting, that even then they knew that pregnancy and maternity was multifaceted, psychological, social, and physical. I could spend hours talking about the history of obstetrics and where we are, but let's be honest, the past 300 years, it's become more interventional. The first cesarean section carried out in the United Kingdom was by a midwife. The past 100 years, we've had antibiotics, we've had World War II to teach us about hemorrhage and improve our postpartum hemorrhage aspects. So the world has changed, and the obstetric landscape has changed. So maternal medicine belongs to everybody. I want to start with a case, just briefly. So this is a 33-year-old lady I managed last year with the team. She presented at 9 weeks. She's got something called Alström syndrome. I had to look it up. 1 in a million people have it. It's a mutation of microorganelles in the mitochondria, i.e. it's systemic and affects everything, eyes, kidneys, heart. And this is a true maternal medicine case. Everybody had to be involved, and I'll tell you about her a little bit later. But as you can see, she couldn't see, she had disability. She was obese. She had cardiac disease, she had kidney disease, and she had diabetes and many others. But when we think about the world, this is the latest data for maternal mortality up to 2020. It was only released earlier this year. We know that every 2 minutes a woman dies, and that's about 820 women a day die. 95% of them are in low-income and middle-income country, and as you can see from the graph, where we are the palest blue, yes? So we are one of the palest blue, but there is still a lot to do, and there are differences between the UK, Europe, and obviously America is doing much worse than us for many different reasons. So where are we going to go? So first of all, we've got to remind ourselves what our census tells us. And I hope you've looked at this, and it's worth you looking at this. This is a graph that tells us about deliveries across the past 21 years and how things have changed. Okay. So first of all, if we think about pre-World War I, where we were, and that maternal mortality, that we were having babies. Then we had World War I and World War II, and it dropped. And then really COVID has now led us to have fewer pregnancies in the UK, and that is a trend globally. So why is it that we have fewer pregnancies, but women are dying, and we're talking about morbidity and mortality? We talk about Embrace, and there's not anybody here that doesn't know about Embrace, so I'm not going to touch on it too much. But what the beautiful thing about a report like Embrace, it gives us themes. It tells us that there are systems and things that are changing, and the work that Debbie has just shown explains that. But more importantly, it's the tip of the iceberg. For every more death that's happened, there's morbidity, and sadly, I'm sure there's everybody here that has felt that for themselves, for moral injury, but more importantly, the woman and her family have been affected by it, both at the time and long term. I have no shame in reminding us all about this hatched graph that we all show every time we launch an Embrace launch. And you know at the bottom we have why a woman dies. We change it into hatched and dark purple. So hatched are pregnancy reasons why, maternal reasons why, and dark purple are the indirect, i.e. the reason why I've got a job as an obstetric physician. And sadly for this year, it's thromboembolism that is the number one reason why somebody dies in this country. And isn't that sad? Don't you think it's really sad? Okay, we know about COVID. We've learned so much about what we would do for a pregnant woman because of what happened in COVID to our women. But I think it's really, really important that we understand that. But let's hear the good stuff that we've changed in, and that's obstetric anaesthesia. Okay, preeclampsia, I think, is a different story. We'll be talking about it next year in Embrace. Watch this space, and so much more to do. But if we think about venous thromboembolism, for those of you who've looked at the presentation or were there on the day of the report, we did look about the timing of the venous thromboembolism of when a woman died. So out of the 63 women that died, as you can see, the majority of them died, if you look at the x-axis, is either in the first trimester or intrapartum or postpartum. So intrapartum and postpartum is risk assessment and timing, etc. And we know that's a difficult time. But first trimester, who does that belong to? And this is why I say, as a physician, a pregnant woman and a woman of childbearing age belongs to everybody. Because these women, sadly, when we looked at them, each case, 5 women had a history of having a venous thromboembolism in the past. She knew she had to have a low molecular weight heparin injection. Some of them didn't know where to get it from. Some of them were denied it, and they died. Some of them had severe hyperemesis and immobility. And that we know is a risk factor with the hypercoagulant phase of pregnancy to worsen this, and they died. And then again, obesity and advanced maternal age are big risk factors. This graph is a little bit more complicated, but I think look at it for the past 3 years and think about the changes. So this one tells us about the selected characteristics of women who died. And again, it's indirect and direct with the hatched. And I've highlighted the ones in red that I think are important, and that's mental health. Okay, well, the women who died were more likely to have a mental health, whether they were an indirect or direct death. They were more likely to have a medical problem in pregnancy, more likely to be obese, but also that social determinant of health. They didn't turn up to appointments. They'd had fewer appointments than somebody else. And I think that's a real marker for us that it's not just a DNA. This woman is vulnerable for lots of different reasons, and what are we going to do? So as a diabetologist, I've got a job for life, haven't I? Obesity, it's a pandemic, it's getting worse, but we've got some great drugs, guys. We've got some great drugs, and we need to get them into our women before they have a baby, or at least in the interpregnancy health aspect. So the graph on my left-hand side are 2 charts. Okay, the top chart shows you that not the obese, but the overweight women, okay, and men, and the bottom graph tells you the obesity weight. What I want you to remind ourselves is you're more likely to be a man and be overweight, but you're more likely to be a woman and be obese. That's not good. We've got to change this, okay? And I want us to remind ourselves when we talk to women. It's really hard, and don't get me wrong, I've got it wrong many, many times as a diabetologist trying to talk about health. Motivational interviewing helps, and you've got to get into a way of how we can help the women to lose their weight. Obesity is a problem. It has effects on the mother, baby, but the mother comes in with heart disease, diabetes, obstructive sleep apnea. She comes with morbidity and multimorbidity. And this is why we see a change, and you can see why the obstetric landscape has changed so much in this country. Secondly, advancing maternal age. And again, this is from the consensus data. And this goes back, I think, about 60 years or so. But what it tells you, okay, is that as the years have gone on, and particularly in the past 10 years or so, the number of women of raised maternal age, i.e. 35, 40, 45, is increasing. And what you can see is where I've put the arrow is that slowly women over 40 is rising, okay? So the majority of them are between 32 and 38, yes? Okay, but the number of women that we have over 40 is rising. 45 now, we see so many. We have over 300 at St Thomas's, and the oldest woman we've delivered is 62. But as we know in the literature, 68 is the eldest, and that was in Africa. America had that game, but it's now in Africa. So that's not normal, okay? But we've got uterine transplants happening. We've got advanced maternal age, we've got IVF, there's many things happening, and our world is changing. So when we think about maternal medicine and the landscape, I think we talk about multimorbidity. And I really love what the WHO and the Academy of Science considered in 2017, 2018, when they said it's a co-occurrence of at least 2 chronic conditions. So that could be obesity, mental health. It could be diabetes and respiratory. And I don't think it only matters for long-term health. I don't think we should only be worrying about our own health as we get older. I think our women walk in with this now, and that's why the obstetric landscape has changed. And if we think about what the WHO said in 2018 about multimorbidity and the consequences of its effect on mother and baby, there's nobody here that doesn't know this, the consequences of the adverse outcomes for the mother, the baby, the preterm delivery, the stillbirth and the loss, but also the moral injury and the psychological influence of going into intensive care or becoming sick and lots of things happening to you and then wondering where you are 5, 10 months later. But what was really interesting that even then in 2017, 2018, they highlighted that globally diabetes, hypertension and psychological health, okay? And I think after COVID, these are the 3 things we talk about, no? Okay. But I think what's really good in the non-pregnancy data is they've looked at clusters. They've looked at clusters of long-term maternal health and long-term non-maternal health. And I would say that those clusters align with our clusters in maternity. I.e., if you're obese and you've got hypertension, you're going to have mental health. Okay. If you've got musculoskeletal and you've got mental health, you may have some issues with mobility and disability, which is affecting you. So there's these clusters of people that are coming to us, and our women do not come with one condition. They come with 10 conditions. And I think it's impossible at a booking appointment to risk stratify who is sick, who needs who, what, when, what, how. And I personally, as an obstetric physician, everybody is sick to me until I've de-escalated them. Because my head, otherwise I miss the point. I've got to go step back to step in. And I think we really need to drive that in maternity. Because the issue is, my goodness, there isn't, I think all the guys over here, including myself, we were in too many guidelines. We've got so many guidelines. But how do you read which one where? And which bit of it means something to you? And that critical thinking is what we are good at. Okay, we got clapping hands for the NHS and COVID, but what you are all really good at is critical thinking and getting that aspect of it right, okay? 95% of your day, you're doing what you normally do. It's that 5% that you actually make a difference, and that's because you bring that right information together. And this is where it's that treatment burden of the pregnant woman in maternal medicine and the social determinants of health matter. Now, this is actually a paper from non-pregnancy, which I've kind of modified for pregnancy. We put the pregnant woman in the middle, and we think at the top green, and I think it's too small for you to read it, but I'm really talking about, what conditions does she have, what drugs is she taking, is she adherent, what are we going to do about it, okay? The sad thing is our women have about 5 appointments a week. I had one yesterday, said to me, Anita, I've been to 3 appointments every single day. Which one is important to me? Isn't that sad? So we've got to rethink and become more seamless and one stop. And then the blue bit is actually the social determinants of health and the fact that where are you going, who are you going to? And I think up here, unlike London, where I've got the tube to get to most places, you've got miles to go from one place to another, and it's not easy. And I really love the work that you've done and the rest of Yorkshire about looking at this and understanding where the priorities are, because that's how you're going to make a difference. So for me, it's the blind man touching the elephant. And I always feel that we're all working in silos. And I've spent my career on trying to work not in silos. I think the woman should be the centre of everything, and we all work together. But what I know, if we look at the pie chart on my top right-hand side, is that a woman will come in with known medical conditions. She will have obstetric syndromes that happen to her, whether that's gestational diabetes, hypertensive disorders, or pregnancy. And then there'll be the de novo, or the unmasked, or the COVID didn't happen, so I didn't go and see anybody, women that we are now seeing. So we are constantly working through this. And I think this is where our critical thinking and my risk of burnout personally occurs, I think, particularly in the past few years, because I'm constantly trying to flex which one should I be doing when. And as my colleague said to me yesterday, Anita, you make 1,000 decisions a week, you're going to get one wrong. You're going to get it wrong. So you've got to accept your moral injury yourself as well. So maternal medicine, multimorbidity, how do you approach it? That was your question to me, Debbie. And what I would say to you, that personalised care, it's got to mean something to the woman and to you, to both of you. You've got to identify them early. So I love the work that Hannah and Tony are going to talk about identifying the deteriorating patient early and what you're going to do. But I think identify early, full stop. What are your risk factors? Everything is a risk factor in my world. Make it yours. And the clinical assessment is essential with the surveillance, the psychological aspect, and getting the buy-in of the family and everybody else is essential, I think. So the heart of the matter and the social landscape has changed, okay? Whether it's Better Births, whether it's Embrace, whether it's the Kirkup or the Ockenden report, we know we need to make a difference. And some money has been fueled in. I know we're walking into 10 years of austerity, but we're good at what we do. It's not the money that we need. We need the headspace and the process and the seamlessness of work. And this is where the maternal medicine networks, I think, are key. Because why do we need them? Because we need to reduce inequality. Okay, it shouldn't matter who you know or who you saw. It should happen to every woman at the right time, reducing maternal deaths and improving morbidity. Think about the problem, and I've kind of highlighted a bit of it already. And then the early working together. So the intensive care network, the maternal medicine network, whether it's the aortic dissection network, we've got to be working together so that you have the right person at the right time working together. And this is where your maternal medicine networks are key about that connectivity. So what are the maternal medicine networks? I know you have one here. We've got 17 across the country. Donald Peebles and Charles Podges did a really good job with Sarah Winfield, David Williams, Kathy Nelson-Peace, and Lucy McKillop. Okay, they did a really good job in setting up the maternal medicine networks. As you know, NHSC have now dropped the hat and said, we've set them up, it's now your way to go. So we now need to be smart, and you need to be smart of what you're going to do next and how. You know you've got a bit of money for the leads of your obstetric physician, and your lead midwife, okay? But you need everybody. Everybody needs to be part of it and connect, because that's the only way you're going to really work on pre-pregnancy, antenatally, postpartum, and improve things. And I'm going to give you an example of how the maternal medicine works for obstetric cardiology, because that's a particular interest of mine. So modified WHO classes 1 to 4 is how we risk stratify pregnant women with cardiac disease. 1 to 2, you're not so sick, you're going to be okay in pregnancy, and we don't need to do anything special. 3 and 4 class, sick, you've got 10 to 20% chance of dying in this country because of what you've got, and it matters where you deliver, what uterotonics you use, and what postpartum health you have. So please look at the specifications and ask yourself, why are they split into A, B, and C? And I'm showing you why we've done it for the cardiac conditions. Because as you can see at the bottom, category A, you can manage at your district general hospital, your local hospital with the right expertise. And Debbie, you've done my job, because exactly the same thing. You've got to work out what you can do and not do. Because you know what, 1 year you might have all the people, the next year they're all burnt out, no one's there, and you've got a different group of people. So we are always forming and storming our teams, which is so different from what I started as a houseman many, many years ago. And that is a realization of why this is difficult. It's not, why didn't you tell me about it? Because last year you could have managed an arrhythmia. This year you can't, because you haven't got the right person there. So this hub and spoke really matters, and at the centre is your maternal medicine hub, okay, but you've got your maternal medicine sub-hubs, so work together, okay. Then you've got your periphery, and you've got your general practice, you've got your community, you've got your ED, and you've got your acute medicine, so all the specialities are involved, and we've got to buy that in. Maternity, we need to stretch out, okay. The MEaCC gives us a chance, you know, from conception to 4 weeks later, and more importantly, I personally think it should go 1 year later, is what I think. We should go for that period of time, but we need to buy in with everybody else. Because if I think about the obstetric cardiology women that we serve, we have about 90 at St Thomas's a year, and 50% of them are modified class 3 and 4. So yes, there's a 10 and 20% chance of them dying. So they're the ones that I worry about, and I know what they can decompensate with, okay? What I need for maternal medicine and working together is, have they got preeclampsia? Have they got gestational diabetes? And we've got to work together to understand this. They don't come with, this is what's wrong with me. They come with symptomology. They come with shortness of breath. They come with chest pain, yes? So there's a massive, massive reason why they could be presenting to you. And I guess for maternal medicine, what we're doing now is understanding, how do we unpick this? And this comes back to what I said earlier, that think of your critical thinking. You've got to have a better understanding of, this fits, this is what it looks like, but actually there's a few red flags here that I need to think a bit more. And when you're busy and your head is in the sands, as can mine be, you can miss these things. And that's why you've got to work together to understand this. And I would encourage you to look at the acute care toolkit from October 2019. And my biggest regret is I should have made that a multidisciplinary in RCOG, RCM, RChem, and an RCP piece of work. At the time, it was an RCP piece of work. So in the last few minutes, training, and who we are and what we're going to become. So there's a lot of changes in the training programs, and NHSC are really leading on this, and there's been lots of workshops and discussions about it. There's so much to do for maternity. You really were, I believe, given a raw deal, actually, I think in the past 20, 50 years. We could have done better. As a doctor, I've always had a study leave. You know, I've had 30 days as a doctor in training, and I get 10 days a year as a consultant. Why haven't we given you that? Statman and mandatory training is not study leave. We need more. So I think I'm a real driver for that, and I think there will be changes with the leaders you've got there now. For obstetrics, we're changing. We've got maternal medicine SITIMs, so this is about capabilities in practice, so it's changing for you as obstetricians. And for medicine and anaesthetists, we are really trying. So as an obstetric physician, we did write a curriculum for a physician to learn about medical problems in pregnancy, and I'm pleased to tell you that Jeremy Hunt did give £1 million to get that up and running for the post-CCT fellows that we've trained, and you will have them across your network. But more important, it's the higher specialty trainings, it's the doctors in training, the resident doctors that we need to engage. But the honest truth is, it's multi-professional. And it's days like this that you remind yourself that it's working together, inter and intra-departments, understanding where we are, because critical care is the tip of the iceberg, isn't it? It's where did you get there, how did you get there, and what are you going to do to try and prevent them getting there? Or more importantly, when you need to step down, what should we be doing with them? So how much and when do you learn and how? It's a conversation for another day. So what does the future hold? I think the future is really exciting. I think technology, I've told you at the beginning where we are with obstetrics, but I think the modern obstetrics and modern medicine is changing. We've got genomics, we've got precision medicine, we've got point of care testing. You know, one day we're going to have PLGF, aren't we, as a point of care testing. Go out in the community, test somebody, your PLGF is less than 12, you're going to have preeclampsia, please come in, your PLGF is 300, you know what? Go and look after your child, stay home for another day. You know, we've got to change the lives that we lead in, okay? Remote care, we've had to kind of struggle learning that, haven't we? with COVID. I don't know about you, I found it really hard, and I still find remote care hard. I like talking to my women and patients and people face-to-face, days like this. But you know what? We're learning, and we should continue to. Technology, so as a diabetologist, I've got the insulin pumps, haven't I? I've got closed insulin pumps. I'm sure you have seen them in your areas. So suddenly I've got AI and mathematical modelling giving continuous insulin to the woman, and I've got them giving continuous blood glucose monitoring. But as my patient said to me yesterday, she said to me, Anita, you know what, I wish I had a Siri. I wish my closed loop could talk to me. And then she said to me, you know what, I think I'll just argue back with them. Okay, so technology is brilliant. But what I said to her was, you know what, it only works if you work on yourself as well. Because you've still got to eat at the right times. You've still got to take your bolus. And there's a lot to do. But I think embrace technology is what I say to all of you. Okay, take the opportunities for those conversations for long-term health. Okay, be brave, push it a little bit further, and understand this a little bit more. Okay, the connectivity across the systems is essential, and I welcome the ICSs and integrated care systems. I think we've got a great opportunity in maternity to work not just with the LMS but across with community, with all the specialities, much, much better. The Women's Health Strategy, I've got to talk about it because maternity is a bit of it. Dame Leslie Reagan has launched this and leading on it for the past 2 years. Embrace it, but the life cycle of a woman matters. The preparation before, have they been to ITU before? What happened to them then? What morbidity are they coming with? The preparation afterwards for their long-term health matters. And all of you know here that hypertensive disorders in pregnancy, as the graph and the table on the bottom, my bottom left-hand side tells you, that if you have a hypertensive disorder in pregnancy, you have a 2 to 4-fold higher risk of cardiac disease later on, or cardiovascular disease later on. If you have gestational diabetes, you have a 60% risk of getting diabetes in the next 10 years. So your obstetric syndromes matter. I'm pleased to tell you there's a nice piece of work coming out from the RCP that we're working on to look at hypertensive disorders in pregnancy and looking at that postpartum health. So returning to my woman, so what happened to her? Well, obviously she delivered preterm, yes, 29 weeks. Obviously it was because of preeclampsia and the obstetric syndrome. That was a no-brainer. She worked and lived, she was looked after in one maternal medicine network because that's where her rare condition is. She lived in a different maternal medicine network, and she delivered at our maternal medicine network, okay? Crazy. But she walked in with lots of multimorbidities, with her diabetes, with her hypertension, her chronic kidney disease, and that heart that we kept echoing, okay? She got preeclampsia, and then we found her to have obstructive sleep apnea during the pregnancy, so she had so much. And it's for this reason, Debbie, that we sent her to ITU after delivering her, because we felt our enhanced care unit was not up to managing her, because we had got so far with her, we didn't feel we had the right tools there for her. And remember, she's blind, and she's come with her dog, not in ITU, but she's come to clinic. And she says, Anita, you didn't let my dog come to ITU, but she said to me, it was the most peaceful place in the whole hospital. And you two are laughing, but that's what she said to me, for her to say, that was fascinating. So my take-home message to all of us is embrace our new way of working in the obstetric, in the modern obstetrics that are in the 21st century, okay? Shared decision-making and working together is going to be key, and it is bi-directional. Women's health matters, and optimizing it throughout this course is where we should be heading. And I call for a maternal care bundle. I think the maternal care bundle will help us put these tools together. And the morbidity burden, we really need to reduce it at every single place, and that is policy for every single one of you. So my last message is prevention is better than treatment. Thank you.